exercise their choices to determine their HIV status and to prevent HIV acquisition. So in today's presentation, we are going to have highlights of examples of innovative community PrEP and PrEP delivery models in South Africa, Kenya, and Zimbabwe. As we embark on this journey and share insights and experience, let us reaffirm our commitment to a world where HIV is no longer a threat. Thank you, and may our collective efforts pave way for a healthy and more resilient world. Thank you very much.
So thank you so much, Patrick, and thank you to SIF for sponsoring this session. For those, as Patrick had described, SIF has given a very generous donation to the Global Fund to expand PrEP delivery in 6 countries: Kenya, South Africa, Uganda, Mozambique, Nigeria, and Zambia. And part of this, sorry, next slide, please. And as part of this investment, SIF is hoping is requesting countries to utilize differentiated service delivery in PrEP uptake and delivery. So that's getting PrEP, oral PrEP, long-acting PrEP, inclusive of dapivirine vaginal ring and injectable cabotegravir, into community settings, into diverse delivery methods to make PrEP more accessible for those who want to access it. So my name is Michelle Rudolph. I work with the World Health Organization based in Geneva, Switzerland. And as I introduce this really exciting panel, people have come in just for this session. I just wanted to highlight some of the work that WHO is doing in support of differentiated and simplified PrEP service and delivery. And just highlighting here, in early 2024, WHO will be coming out with an updated version of our PrEP implementation tool, previously called the clinical module, is now being updated to the providers module because we want to emphasize the importance of task sharing and utilizing the whole cadre of health workers, doctors, nurses, clinical officers, pharmacists, and other community health workers. Next slide, please. And then in this document, And then here I just wanted to highlight that last year, WHO released a document on accelerating PrEP scale-up through differentiated and simplified PrEP services to support the demedicalization and simplification of comprehensive PrEP services. And I'm highlighting this here because I know that for many people sitting in this room, before you can move forward with your programs, governments need to know that WHO supports these changes in programmatic implementation. And please reach out to me afterwards for copies of the slides. I'm happy to share. Next slide, please. And with that, I would like to introduce, let me put my glasses on. I'd like to introduce Angela Tembo from Azintra in South Africa, who's going to present on utilizing private pharmacies. So I'll let Angela take it from there. Thank you, Angela.
Can you hear me? Yeah. Perfect. Okay. Thank you so much for that introduction, Michelle. And I will run you through what we are doing in South Africa within the private pharmacies. So South Africa has a large pharmacy network, and often we do see people presenting into pharmacies who's accessing sexual and reproductive health services such as STI treatment and also emergency contraceptives, often signifying high risk for HIV infection. So this opportunity really provides, this platform, pharmacies provide an opportunity for accessing that population and potentially putting them on PrEP. Next slide, please. So in terms of background, okay, so these are the wrong slides, but I will go through what I have here. So South Africa has over 3,500 private pharmacies, which offer an array of sexual and reproductive health services, including HIV testing, contraceptives, doctor-issued prescription, including ART, PrEP, and PEP. In addition to this, pharmacies are a site for baby immunizations, and recently we're quite influential in the COVID-19 vaccine rollout. As I earlier alluded to, uptake in PrEP in South Africa has been very slow, despite very well documented guidelines and an ongoing pandemic with a high prevalence of HIV, and strong implementation research which has showed efficacy data on PrEP and good donor support. But despite this, there has been slow uptake. And accessibility really plays a huge role in the slow uptake, and pharmacies have the potential to increase coverage, especially among young women and high-risk men. So there are over 3,500 pharmacies, like I said, and these are a mixture of community and also commercial pharmacies. And in most pharmacies, you will find a nurse who leads some of the primary healthcare services provision. And until recently, the South African Pharmacy Council introduced the PMAT program to allow our pharmacies to initiate clients presenting in pharmacies on art. PMAT is currently being contested, so for now, we are using a nurse-led approach for our project. Based on this background, what we did in 2021 through a human-centered design approach, we looked at the acceptability of introducing PrEP in pharmacies, and we interviewed various respondents, including young women and men, and ranking high on what made pharmacies more appealing for them as PrEP sites were confidentiality, no judgment, and trustworthiness. Next slide, please. So based on the background I've provided, we designed an intervention. So this is a very small demonstration study, and we're targeting 1,900 men and women above the age of 18. In our initial proposal, we had capped that to 35, but about a month or two into implementation, we saw a high demand of PrEP from people above 35. So we had a protocol amendment to include anyone above 18. So the main objective for the study is to establish visibility mainly and suitability of pharmacies as PrEP delivery sites. We have secondary objectives. We have an end-to-end, we are trying to evaluate the feasibility of an end-to-end virtual platform supported by HIV self-testing for PrEP maintenance. We are also going to be looking at assessing real-world preference of injectable PrEP or cabotegravir versus oral PrEP. And lastly, we'll be assessing all these models for cost effectiveness and preference. So in terms of the project, like I earlier alluded to, it's currently nurse-driven. And because of the challenges around what nurses can do, non-professional nurses can do in South Africa, they have to be supported by doctors for the scripting. So a client will present into pharmacies and they are recruited from different areas of the pharmacies, including aisles and the dispensary unit section. After that, if they're interested in PrEP, they are referred to a nurse. The nurse will have a discussion on risk, conduct an HIV test, as well as conduct the necessary baseline investigations required for PrEP initiation. Once the client has been deemed eligible for PrEP, a nurse facilitates a doctor consult through a virtual call, and a script is provided immediately. After that, the client walks out from the nurse's consultation room with their script and goes to the dispensary where the PrEP is dispensed and the follow-up appointment is made. Next slide, please. So I updated this slide, and apologies that you won't get to see updated numbers. We provided this information when we were conceptualizing the session, so that when the numbers have moved slightly. We are currently sitting at 575 participants who have enrolled onto the project. We started in June, but we used a very staggered approach, bringing on pharmacies on board. We currently have 11 pharmacies as at the end of November, and the current split is really even between men and women, and our continuation rate is sitting at 35%. So just before I wind down the presentation, and because it's very early stages for us, and I think what's important is to share some of our experiences and what we are currently seeing. I think the Kenya team will probably provide much more data in terms of continuation and some of the risk that is in the people that are presenting on PrEP. But I think just key lessons, every time we present our project, I think there's quite a lot of interest in terms of like how did, what has worked, what hasn't worked, and what has been our experiences in running our PrEP. So we are seeing that both men and women are accessing PrEP through pharmacies. There's quite a high demand, especially among people, among pharmacies which are closer to institutions of higher learning. We are also seeing that HIV testing is not a deterrent, so people are willing to wait for their test results to initiate PrEP. There's some confusion still, and I think the pharmacies are not, they're probably the best caterers to work with. They adhere to guidelines, they're very good at M&E systems, but there are general gaps when it comes to aligning with national guidelines. So we have spent quite a lot of time to try and build capacity within the pharmacy, among pharmacists and nurses that are operating in pharmacies to avoid this confusion between PrEP and PrEP. And my second last point is that, and then really this is almost like a call to action around the current barriers related to legislation in South Africa about who can and who cannot initiate PrEP, but also around the use of self-testing. We do see that self-testing has a potential to support PrEP continuation, but because of our guidelines, we are unable to do so. And we do appeal to anyone from the Department of Health in South Africa to really look at that, because we have very good evidence from the WHO on HIV self-testing and PrEP continuation. And lastly, so pharmacies are good at demand creation for products, so they can promote medication through partnerships with pharma, and they have systems that exist. So we are not creating parallel systems for demand creation, we are using the systems that currently exist within pharmacies. Next slide, please. I would like to thank our partners on the project, the CLICS group, the Discount pharmacies, the independent community pharmacies, our online platform, King Online, the Clinician Society for the capacity building, and also our partner, economic and evaluation partner, HERO, at the University of the Witwatersrand. Thank you.
Angela, thank you so much for that comprehensive presentation. I am really, really encouraged seeing the use of pharmacists to roll out PrEP and cabotegravir, and I just encourage you to also consider this dapivirine vaginal ring in the future when Gates pays for that. So I'm going to hand over to Dr. Kenneth Ngiri from Jomo Kenyatta University in Kenya. He's going to share Kenya's experience on pharmacy-delivered PrEP and PEP. Next slide, please. And we're going to hear another example of task sharing in Kenya. So over to you, Dr. Ngiri.
Thank you. I'll probably stand so that I can project my voice better, because most of my other things that I do is I teach, and when we teach, we usually stand. So probably this is what I'm more used to. So I'm going to talk to you about the Kenyan pharmacy experience. And I'm sure you'll want to ask yourself, why are we focusing on the pharmacies? Even without going to individual experiences, I'm sure that you know that many people access pharmacies more than they access public health facilities for various reasons. One is that pharmacies are ubiquitous. In my country, every few kilometers or every few meters, you'll find a pharmacy. Some of them are open 24 hours, as opposed to the current standard where we are delivering PrEP and PEP, which are HIV clinics, minimum operated 5 days a week, 8 to 4 or 8 to 3 p.m. And so that's why we're going to talk about PrEP and PEP. We'll probably say PrEP and PrEP because we have been doing more of PrEP than PEP. So we started a few years ago to work. Next slide, please. Thank you. And please remind me again if I forget. So we started doing PrEP delivery in pharmacies, but we did not sit and just get into a pharmacy in 2021. We had a stakeholder workshop where we invited people from the Ministry of Health, Pharmacy and Poisons Board, the doctors, KPMDA, the Doctors Association, the Lab Association. So we had various stakeholders, and together we worked on a pathway of pharmacy PrEP delivery. And through that PrEP delivery, we were able to do a pilot study because we were entering into a new space. So we only started with 4 pharmacies. It may sound few. So we started with 2 in central Kenya and 2 in western Kenya, or Nyanza, where we have the highest HIV prevalence. And then after that, after doing that study for about a year, we then moved on and did pilot extension, which was now in 8 pharmacies, 4 in each of the regions. But what were we able to see? Not surprising is that we were able to reach a different demographics. We were able to reach younger men. We were able to reach more men by 57 versus 46%. Younger population, you can see the population in the 40s versus the 20s in other studies. Many of you may have heard about Partner Scale-Up Project, which was done in HIV clinics, the PREA study, which was done in MCH clinics, and PREA in FP clinics. I would encourage you to familiarize yourselves with these studies because they are very instrumental. And we compared the kind of populations we are getting. And as you can see clearly, is that we're able to get populations at higher risk who are able to visit these clinics more often. If you look at, for example, even at another thing like partner, people who have
interacted and engaged women in the communities where the DVR is being delivered, well, under some studies. So women always ask, can my partner feel the ring during sex? And this is one of the top questions that women ask in almost all the communities that we've gone to where the ring is being delivered. And it just got me thinking that why are women so worried about the partner feeling the ring or partner getting to know about the ring? And then I just got to understand that definitely women want something that is discreet to them, something that is going to be known by themselves only and not to their partner. So how about we give them that? A product that is going to be private to them, just like the ring, where they can use it and no one can get to know about it unless they decide to disclose it to themselves, to their partners, or whoever they want to share that information with. All right, so they also ask during our conversations that, so how often do I need to, to go to the facility to get another ring, and, how long does it last, and how does it work? How does one know if it's in the right place? And is it going to affect my fertility? What happens if I go more than a month with the same ring? What happens if I want to change or to stop using the ring? Like, it's some of the information that women expressed, some of the information that women need to know about this ring. And so what we're saying is that women need to get enough choice counseling about the HIV prevention products that are available to them, especially the ring, considering that it's new in our communities. So we want to urge the service providers or wherever the ring is provided in the communities that may enough information be given to women as they decide to use the DVR or as they are choosing the HIV prevention method that they want. Next slide, please. Okay, still focusing on what women want with the DVR or the dapivirine ring and what it will take to make this ring delivery possible in the communities or in the pharmacies. So I was just thinking that how about we have youth-friendly spaces as delivery service points for this DVR, especially for young women. We know like how it's a toll for a young woman to just go to a health facility, especially a community clinic or hospital. So how about we use the youth-friendly spaces that are available, maybe like the community youth centers where young women frequent, where they are free, where they are happy, where they feel welcome, and where they do so many other activities besides accessing health services in those spaces. So how about we just have our ring and other services being delivered in such spaces? That can really help in the delivery of the ring and maybe other sexual reproductive health services in our communities. And also, how about we have a one-stop shop for delivering this DVR in our communities? So imagine a woman when they are thinking of going for their family planning services, when they need menstrual hygiene services, or maybe when they need STI screening and treatment, or they just need HIV testing services. So how about we have these integrated services being delivered at one point, be it in the communities or the health facilities that are accessible to them. So I think it's one of the things that can help the DVR delivery possible, whereby we have service layering at one point for women. That would be very convenient and that would be so cool for many women. And if we can also talk about the flexibility in service provision to also increase access. So we talk about the differentiated services at this point. So can I get the ring whenever I want it in the communities? It's being introduced to women in the communities for all the women. So how about I get it whenever I want it? I don't need to think or stress about well, we now have this long-acting method that I'm interested in using, but am I going to get it? So how about we have it available whenever women want it? Also, can we also have the DVR? How about if it gets delivered in places that are convenient for all the women? So you don't need to stress about where you need to get it, or the cost that you may incur while it's trying to get the ring and everything. And also, who is going to provide that ring? Where I'm going to access the services? Do we have the competent staff that are trained in all these new methods? Am I going to be satisfied with the services that I'm going to get? And also remember, this also plays a critical role, because the person who is going to serve me whenever I want the DVR ring is going to determine if I will continue using it, if I will go back to get another one, or if I will even recommend it to my peers or someone else. Also, what can also help is to have the affordable access to services. If it's going to be physically accessible to women, like they can get it anytime, whenever they want, and also, no out-of-pocket costs for women to get the DVR. That can also help. And also the community-based service delivery provision. Many a times when you need something or maybe some medication, you just have to go to the clinic or the hospital. But how about we just decentralize the service delivery for the DVR? We get it in our communities. How about we use the mechanisms that are already there in the communities? Like we have the community health workers that are working in the communities. We have the peer educators, we have village health workers that are in the communities. When I'm thinking of these community cadres, I know that at any time, if you need maybe like condoms, and you see a community health worker or a peer educator, someone wearing a teacher-rated peer educator in the community, you can get a condom from that person. So how about also, they also assist in delivery of these DVR services in the communities.
Nelly, we gotta wrap it up.
Oh my goodness. Okay. Thank you for that. Then next slide, please. Well, so lastly, I would say another thing that is going to help us in the delivery of the DVR in the communities or in the pharmacies is what happens within the health facility. The healthcare provider attitude. I know this is an old song that we've heard so many times, but it still has impact in the delivery of these services. So I just want to suggest that whenever we have these new products, let us have competent service delivery the providers who are well trained in this, because one of the barriers or something that can promote the uptake of the service is the support from the provider who is giving that service. Let us also have support from the parents, the peers, and also the partners. There are so many ways to engage this so that we have a successful delivery system for the DVR. Thank you.
Could we have the next slide, please? Here's Nelly's acknowledgements. We're now, Nelly, thank you so much for your passion and sharing with us what women want. And I really appreciate hearing that, and I hope others in the audience feel the same. We'll now move over to our last speaker, Linda Gale Becker from the Desmond Tutu Foundation in Cape Town. Over to you, Linda Gale. Next slide, please.
Thanks, Michelle. Thanks, Patrick. And thanks to great panelists who set this up. My job is really to look to the future and where we are going. So we are in the midst of a choice revolution, which is very, very exciting. It's a choice on many levels, and the choice basket is getting even fuller. So what I can tell you is, besides the ring, the long-acting injectable, which we hope will be coming to us all soon, and of course, good old faithful oral PrEP, which you can take daily if you're a woman, intermittently if you're a woman and a man. And as a man, you can take the 2-1-1 event-driven process. That is already in our cache, what's coming. So you'll see on the far right, we have this very exciting new drug. It's a capsid inhibitor called lenacapavir. This is an agent which is also an injectable form, but it's a subcutaneous injectable rather than an intramuscular injection, and you have to take it every 6 months, 2 injections a year. So that is incredibly exciting, adds more to the long-acting, less frequently dosed PrEP. And of course, we're looking out for that. So there are at least 4 studies ongoing at the moment to see if it is efficacious in a variety of populations. Purpose 1 is happening here in women who have sex with men. Purpose 2 is also happening here and all over the world in all kinds of populations, including men who have sex with men, non-binary people, people from the LGBTQI community. And then there are a couple more studies looking at, for example, people who are transitioning using hormonal agents or injecting drugs. So very exciting portfolio. The studies include pregnant women. It includes teenagers. So we're in good shape with lenacapavir. Hopefully coming to us next year or the year after, depending on how well the studies go. So very exciting. Then in the middle, there's an array of all sorts of wonderful things happening. Matrix, Conrad, other agencies are really looking at a whole range of patches, needles, inserts, you name it, films, you name it, it's happening. There's a lot happening around the ring in particular. And of course, then there's the immune-based interventions. So you can have monoclonal antibodies, and we're all working very hard on vaccines as well. That's probably a little bit further that way in terms of the future. But just to know we haven't given up on an HIV vaccine or a monoclonal antibody to prevent HIV. Next slide. Very, very exciting. Whenever I tell women about this, they burst into applause right away. This is the concept of multi-purpose technology. Now, we've had the condom. That was our first multi-purpose technology. Protects us against STIs, HIV, and pregnancy, right? But we need something more than a male latex condom, without doubt. And very exciting that this is also coming. A lot of them associated in the ring, but also exciting, right at this moment, we're trialing, and this is Viatris that's putting this out there, is a single pill that combines oral PrEP and hormonal contraception. So women, this is our first sort of opportunity to know that we're protected against pregnancy and protected against HIV at the same time. Extraordinary breakthrough. That trial is underway. And the third slide, because I was allowed 3, next slide, is really about where I think we're going in the future. And this is really what WHO has been about. This notion that we are moving into choice in a 3-dimensional way. So I'm going to describe this to you. The first dimension at the bottom, you see we're getting choice of products. So I'm so excited about that. That is wonderful. But it needs to go hand in hand with the choice of delivery methods. And what you've heard here are a couple of examples of different choice delivery methods, and you've heard just the call for it. So this is an exciting time when we say, can we move out of facilities into communities and offer people their prevention choices in mobiles, in pharmacies, at school, at the hairdressing salon, wherever people are. When we went to young people and we said, what is the barrier? They said it's access, access, access. We like choice of product, but access is what it is all about. And I can tell you that in Cape Town, I'm going into one community of 1 million people. We try to access 25,000 young people of all kinds, LGBTQI young women. We're on 15,000, and they can pick it up anywhere, from a mobile, a hairdressing salon, from school, or from a facility if they wish. And we're starting to see persistence increase. So we've gone from a persistence of about 20%, we're up to 50%. So this is what happens, and we're on 15,000. I'm really looking forward to when we get to 20,000. And so nearly we're giving out the ring just as much as we're giving out oral PrEP, and I can't wait to add Cabernet into that mix. And that's when it's going to start to look 3-dimensional. What is the 3rd dimension? It's the person at the middle. Some of us like to go to the clinic. Some of us want to do it very discreetly. We want a courier to bring it in. We can bring rings and we can self-test. When we send it by courier. And we're doing that very safely and very effectively, and even 16-year-olds can do that very, very well indeed. So that is the future, people. It is bright. We have prevention really coming into its own. I'm very excited about where we are going, and I believe we can end HIV with prevention choice. Thanks, Michelle.
LGB, thank you so much for that inspiring presentation. And really just, I hope you all take away from this, the 3D, the choice, the accessibility, getting people what they want and bringing products and services to people where it's easiest to access. Unfortunately, we do not have time for Q&A with the audience. However, I ask any of the presenters who can stay on to take questions for people to come up here. So really a big round of applause to our wonderful presenters, and thank you so much.
Thanks, Michelle. Thanks. Wonderful.